So that's what I will leave you with. One last point is on the treatment of collapsing FSGS. If it is secondary forms of collapsing FSGS, for instance, the classic one is HIV. You will treat the underlying infection, of course, and then you can consider steroid therapies if there is no contraindication and there is severe disease. Okay, so collapsing FSGS is often, though not always, severe in its presentation. Often you have fairly severe impairments in GFR. In those instances, I would not just start treatment for their HIV. If there was no contraindication, I would be treating the HIV plus giving them steroids. Okay, and maybe we'll touch upon that again when we talk about HIV-associated kidney disease. For idiopathic collapsing FSGS, then I personally do not use steroids followed by calcineurin inhibitors if you fail steroids. If you are steroid resistant, I hit you with the 1-2 punch because you don't have a whole lot of time. If you do not respond to steroids and you're giving them 3 to 4 months of steroids before calling it, that is steroid non-responsive or steroid resistant, then you've often lost a lot of ground, lost GFR, have a fair amount of IFTA, and then trying to treat somebody like that with calcineurin inhibitors in round 2 is just pragmatically or practically hard. So because the prognosis of collapsing FSGS is inferior, I will generally use both steroids and calcineurin inhibitor in the idiopathic forms of collapsing FSGS. Okay. All right. Very briefly, we're going to cover, we'll spend some time on post-transplant FSGS, and then I'm going to really gloss over the minimal change disease variants, basically pointing them out, but then moving on to membranous nephropathy. There's not a whole lot of evidence-based guidelines in managing those variants that are considered variants of minimal change FSGS. So briefly, post-transplant FSGS is a real problem. If we were to estimate the risk of this recurrent form of FSGS, we might say that if you look at all comers with real FSGS, let's say primary FSGS, okay, so that's not FSGS from, sickle cell disease. One would predict that that doesn't recur. You would not typically predict that a genetic form of FSGS will recur, though that has been described. So if we're dealing with, again, primary FSGS, trying to reduce the denominator to just primary FSGS, it is estimated that about 20% of those will have recurrent disease post-transplant, okay? There are some predictors that increase the likelihood of recurrent FSGS. And here are some of them, okay? If you change the denominator to just adults with a negative family history, right? So you're trying to exclude genetic forms of FSGS by taking out that family history and fairly rapid disease progression where they reached ESRD in less than 10 years. There is an estimate of recurrence of almost 50% if you were to reduce the denominator to that limited subset of primary FSGS. If you reduce the denominator in this way, where you're dealing only with children, negative family history, and a fairly quick onset to ESRD, time of onset to ESRD, you can see that many patients of those pediatric patients are going to have recurrence of FSGS. If you've had a prior recurrence and you're thinking about retransplantation, then predictably you'll have a higher risk of recurrence in those cases as well. Remember, familial forms of FSGS is protective. We don't invoke a circulating permeability factor in familial forms of FSGS. Usually we think of that as a disease resulting from classically a podocyte mutation, right? So if I give you a new kidney with normal podocytes, you would not presumably have recurrent FSGS. But yet it has been described in some cases of familial, genetically proven FSGS that does recur. In some of these patients, the recipient actually starts to create an antibody that's directed to this neoantigen, right? You give this individual a normal podocyte, right? Which their immune system has never seen because they previously had a mutant podocyte, right? And so now they're developing a form of sort of antibody mediated FSGS, okay? So that's one way this familial form of FSGS can still recur, although again, it is much less likely. Okay. Here are some other risk factors for recurrence. If you're requiring more intensive therapies in order to achieve remission, you might predict that that patient will have a higher risk of recurrence. Heavier proteinuria. Interestingly, there is this kind of racial mismatch that is associated in registry data as increasing the risk of recurrence. If I have a Caucasian recipient and that recipient gets a donor kidney from an individual of African descent, interestingly, that individual has a higher risk of FSGS. Whether that has something to do with that donor kidney having APOL1 risk alleles is unknown, okay? The use of interestingly, using a living related kidney donor in somebody who has primary FSGS results in loss of that survival advantage. Normally we think that if you have ESRD and you're getting a transplant kidney, one of the best sources of transplant kidneys is your living related, healthy individuals, right? But interestingly, when you look at, again, registries of patients with FSGS who have received a living donor kidney, there's something about that once again increases the likelihood of recurrence. And then therefore, there is this loss of survival advantage by getting a kidney from a living related donor, okay? These are equivalent when you look at averages, right? This does not necessarily translate to you should recommend that your patient with FSGS don't have a living donor kidney transplant, because registry data suggests that the survival advantage is not better than just waiting for a cadaveric kidney. You need to inform your patient that that survival advantage may be blunted, but I still would advocate that rather than waiting for a cadaveric kidney for 3 years, you should really be considering a living donor kidney transplantation. They should just have this knowledge in hand as they're making that decision. So again, I don't want you to take away from this. You should not encourage patients with primary FSGS to undergo living related kidney transplantation. Okay?
But these only for related donors.
This is for related donors, correct? Not living donors who are unrelated, right? All right. So pre-transplant management of an individual who has FSGS, you may consider screening those living donors for the APOL1 risk alleles, even if maybe they're not obviously of African American race, because there's genetic admixture. You may still consider APOL1 risk allele testing in possible donor kidneys for kidney donors for an individual. Certainly, that suggestion of testing for APOL1 risk alleles increases if the donor is of Black race, self-identified Black race. Okay, and then if you have individuals who have childhood FSGS, you may consider some genetic testing, and you are suspicious of a genetic form of FSGS in that child, you can also screen some of the living related individuals who are considering living donation, if particularly they're young and have a future risk of developing FSGS. Interestingly, there are, again, individuals who can have genetic forms of FSGS that don't manifest in childhood. Particularly, there are some, one in particular is INF2 mutation and others that occur in adults, where adults can have genetic forms of FSGS that have disease onsets later in life. Okay. And I think I've already said this, the loss of that survival advantage from living related kidney donors. And then when you have several risk factors for recurrent FSGS, which we highlighted here, some transplant centers will try to anticipate that risk and guard against that risk of recurrence by doing a number of things to the patient. You may consider pre-transplant plasmapheresis. You may consider getting calcineurin inhibitor levels detectable and therapeutic even before the patient undergoes transplantation. Others will include rituximab therapy as well, pre-transplant or peri-transplantation, even before there is overt proteinuria that's present. Okay. Once you get recurrence of disease, it's pretty hard to manage, and it's obviously tragic for the patient to go through all of the complications of nephrotic syndrome post-transplantation. These patients in general do not do well. Okay, starting prednisone at high dose is usually part of the recipe. You may consider even IV cyclosporin for a couple of weeks, for 2 weeks. This is based on an now old paper that was not randomized, but a prospective cohort analysis looking at recurrent FSGS in post-transplantation, and using a protocol of high-dose steroids and IV cyclosporin, achieving fairly hefty levels of cyclosporin. So we tend to think of therapeutic levels of cyclosporin being around 150 to 200 shortly after transplantation. These levels are pretty high for about 2 weeks, and then continuing to dose cyclosporin and keeping levels high. Notice here that in this protocol, they used peak levels of cyclosporin as opposed to troughs. I think we briefly touched upon that in the transplant Esquelitas. Unlike tacrolimus, there is a literature that supports monitoring cyclosporin based on 2-hour peaks instead of troughs. So some people have espoused the peak level as a way to monitor that, and that's what was used in this protocol. These patients also received plasmapheresis. I think in general, people are doing a variety of things for these patients, including rituximab. There are some out there that have espoused abatacept. That enthusiasm has faded, but there was a time where there's prominent researchers from the Harvard programs that used abatacept post-transplantation based on some biology that they described where B7-1 expression was detectable in the transplant kidney with recurrent FSGS. Yes.
Can you talk about LDL apheresis for FSGS?
We can.
There are a lot. There seems to be some more. So I've seen this done for recurrent FSGS and also primary FSGS.
You saw that in your pediatric population?
I saw that in pediatric, and also I've seen, I think, one of the patients that you're considering doing LDL apheresis in primary FSGS. I'm not sure.
Yeah, that's definitely out there in terms of the management of FSGS, but let me see if I can do justice in describing that therapy. And you're right, there are two individuals who have been refractory or dependent on multiple therapies and still proteinuric that we've actually explored LDL apheresis for. Okay, what is LDL apheresis? Well, it's basically a magic intervention that we do not understand, where you essentially have a negatively charged adsorption column that can remove LDL particles in severe dyslipidemia, and then remove something in FSGS. Okay, and so this intervention has been utilized for really refractory cases of nephrotic syndrome. And there have been some investigators, all non-randomized controlled trial data, that have shown significant outcomes where a portion of patients, nobody has proven, this is a high likelihood of response. But, in these non-randomized studies, there have been some people who have essentially come off of all therapies or required less intensive therapies. Okay. Who is going to respond? Who is not going to respond? We cannot predict. Now, the FDA has looked at that data and has actually approved the use of LDL apheresis in a program called compassionate use. So you can get approval for what are largely investigational therapies, even in the absence of robust data, if you treat patients who are meeting the FDA criteria for this compassionate use. So in order to have, I don't recall whether post-transplant FSGS, I'm sure it's there as an option, but generally speaking, the criteria that I recall are you need preserved GFR. These guys have to have a creatinine, I forget the cutoff, but it's in the ones. You can't try this in somebody who's got creatinine of 3 and you've already tried everything. They're largely dead kidney now. They have to have preserved GFR and they have to be nephrotic. That's the summary of what this LDL apheresis compassionate use program is. And then presumably, these individuals, which I haven't actually parsed this part of the management, you have to actually report the outcomes of these patients to the FDA who's granted compassionate use for this period of time. So, that's the summary of what I can share with LDL apheresis. We have no idea how it works. We have no idea who's going to respond. It's a very slim number of patients who are going to actually be are going to be candidates for this. You need preserved GFR despite failing all these other therapies, which in general doesn't happen very often. By that time, people have severe CKD. Okay.
They're not going to be connected to a cleaning machine once a week. You can just dialyze them if they have low, like advanced CKD.
Well, the LDA apheresis, interestingly, is not a lifetime therapy. You get freezed, and then some patients, again, are off meds for months.
Nice. Okay.
And we don't know how many freezes sessions you need. I'll share my experience in the 2 patients that we're trying to.
The attending said that they usually do a finite trial, like it's like 12-week something program, and then if they respond at that time, and then if they don't, they just stop.
Yes. Yeah. Just kind of what sounds right. Shoot from the hip. All right. So minimal change. Okay.
Just for the cyclosporine, is that like a titratable drip or?
Yeah.
And like, do you take like daily level, like?
Yeah. Just like cyclosporin given IV, you may see it actually in some of the BMT patients with severe mucositis. Who can't tolerate, oral drugs. You'll see IV cyclosporin in that scenario, and tacrolimus as well. They have IV protocols for tacrolimus. And it's titrated. You generally use about 1/3 of the dose okay? Because you may recall from our transplant lectures that much of the metabolism, the bioavailability of tacrolimus and cyclosporin is reduced because the enterocyte is metabolizing. It has CYP3A4, and it's clearing and metabolizing the drug to inactive metabolites at the time of absorption. And so if you're not having that mechanism of drug removal, then you'd be expected to reduce the total dose by about a third.
Just wanted to clarify, so this recurrence of FSGS, we're thinking, of course, like primary FSGS recurrent soon after transplant, but like sickle cell disease that you mentioned, that would be like a secondary FSGS. It could recur years after a transplant. And I mean, the patient will keep sickling first.
Yeah.
It's just not, just different entities.
Correct. You have to, yeah, again,
Yeah.
just as Juan has mentioned, this is the FSGS that you presume is a permeability factor mediated. And you've highlighted the instance, you know, in which you can invoke or consider somebody getting recurrent FSGS 10 years down the road from ongoing sickle cell effects on a transplanted kidney. Yeah, when you would not use these therapies in that instance. All right, so just very briefly on the minimal change FSGS variants, like I said, there's very little guidelines as to how to manage these patients. In general, you use the same protocols as you would for treating minimal change disease in FSGS. So let's enumerate those. Number one, you do not treat subnephrotic patients with idiopathic mesangial proliferative GN, IgM nephropathy, or C1q nephropathy. By the way, why are these considered minimal change in FSGS variants? Because they often present with nephrotic syndrome, sometimes explosive, and they're often steroid responsive. That's the only reason why these are kind of considered minimal change disease in FSGS variants, because they have distinctive features from those, right? I have, in one instance, mesangial proliferation. With IgA nephropathy, I have IgM nephropathy. I have IgM deposits in the kidney. And in C1q nephropathy, I have C1q on the kidney biopsy. And I can have the pattern of FSGS present on the kidney biopsy. Hopefully that's not confusing to you. Remember, FSGS is simply a pattern, right? And you can see focal, segmental, glomerulosclerosis, a fancy term of scar, really for anything. Okay, so FSGS and C1q or FSGS and IgA nephropathy can coexist. That just means you have IgA nephropathy with scars, right? Or C1q with segmental scars. Okay, don't be thrown off by the fact that I'm using two terms. These are not mutually exclusive terms, right? This is just saying that IgM nephropathy with scarring, okay? And so again, these diseases act like the minimal change in FSGS. And as you can see, that their treatments are generally going to be steroids, okay? So I've added a few more details in here. Maybe I'll drill down just a bit to IgM nephropathy is sort of a controversial diagnosis. Remember, I told you that you can have non-specific IgM deposition. That's your biggest circulating immunoglobulin, and it's sticky. And so in any area of scar, you can see some IgM deposits. So there is some controversy regarding, you know, whether IgM nephropathy is a real entity. Some things that, you know, argue for this, you know, realness or the reality of this entity is this statement here: the non-specific IgM staining generally has no EM deposits. Okay, so if I see the EM deposits plus I'm seeing IgM on immunofluorescence, then I'm more likely to call this IgM nephropathy as opposed to just non-specific IgM deposition in areas of sclerosis. Okay.